Welcome. I'm Dr. Doug Evans, Chair of the Department of Surgery at the Medical College of Wisconsin, and welcome to another one of our videos on innovations and programs in the Department of Surgery. Many of you have already seen Dr. Tracy Wang, Chief of Endocrine Surgery, who has hosted a number of these videos, and we thought it would be good for the two of us to do a brief video on thyroid cancer, a topic that's of significant interest to both of us. As mentioned, Tracy is Chief of Endocrine Surgery here. Her practice is devoted totally to surgery of the endocrine glands, thyroid, parathyroid, adrenal, and gastrointestinal hormone-producing tumors. And Tracy, maybe you could provide a brief intro on just how common thyroid nodules and not thyroid nodules are, how relatively uncommon cancer is, and then I can present you a patient phone call I received actually last night.
Okay. So thyroid nodules are very, very common. It is thought that in the adult U.S. population, probably more than half of adults will have thyroid nodules, and many of the time they won't know that they have them. And so we see a lot of patients who have thyroid nodules that are picked up when they get an imaging study like a CAT scan or an ultrasound for a completely unrelated reason. But as you mentioned, thyroid cancer is still exceedingly rare. There's a lot in the mainstream media about the incidence of thyroid cancer increasing and are we overdiagnosing it? And while that's a little bit of a controversial topic that perhaps we can discuss at another time, I think it just does go to show that we're picking up a lot more cancers because of a lot of other imaging studies that are being done.
Sure. And thyroid cancer, is it more common in men or women? And is there an age-related biology to it? I think people have heard that maybe it might be a little, if you're going to be unlucky enough to get thyroid cancer, maybe better earlier than later. But what's the true story there?
So it's more common in women generally, although we think that men who have a thyroid nodule may have a higher likelihood of having a thyroid cancer. And there's typically sort of two age groups where we see thyroid cancer really, either in the younger population, so late teenage, early 20 years, and then generally we see the most patients sort of in their 50s and 60s.
Okay. So last night, I'm actually on my way to a dinner meeting, and I get a call from a woman who's probably a few years younger than me, who I've known forever. And I've known her in Massachusetts, where we go sometimes in the summer on Cape Cod. And so she went to her physician, and her physician palpated a thyroid nodule. So she then received thyroid function tests and an ultrasound of the thyroid. Would that be pretty much how you would evaluate that to begin with?
Yeah, that's pretty much the standard for initial palpation of a thyroid nodule. Thyroid function tests don't necessarily tell us whether or not the nodule is going to be a cancer or not, but in someone who has a thyroid nodule, at least a thyroid stimulating hormone level is helpful to have in the evaluation. And a thyroid ultrasound is really the standard diagnostic examination.
And if the TSH, or the thyroid stimulating hormone level, is normal, then it probably wouldn't mean anything. If it's a little bit low, that's really the reason you checked the test, correct? To see if it was low.
Right. If it's a little bit low, then it might suggest that the patient is a little hyperthyroid, which would affect the studies that are done and perhaps the treatment options that are available.
So she recited to me that the thyroid nodule was about 1.6 centimeters in size on the left side, and on the right there were a couple smaller nodules, and that the recommendation of the ultrasonographer were for her to then undergo a biopsy of the thyroid of that nodule that was a little. That she said she was told that it was over 1.5 centimeters. Granted, it's just a little bit over, but because of that, a biopsy was recommended. Would you pretty much agree with that?
It depends a little bit on the characteristics of the nodule on the ultrasound as well. So solid nodules over 1.5 centimeters, certainly we would recommend biopsy. If it's cystic or it looks like there's just fluid within it, those tend to be more often benign. And if there's no other suspicious characteristics that the ultrasonographer saw, they can actually be a little bit bigger before we would biopsy them.
Sure. And thyroid biopsy is typically an outpatient procedure, a little Novocaine or local anesthesia in the skin, and then the needle goes in the nodule is aspirated and then it's sent to the pathologist.
Correct.
And I know it gets, because you and I deal with this all the time, it gets kind of complicated as to the results of the needle biopsy, but how would you simplify it, especially for patients and their families who are watching this video?
Sure. There are 6 main categories that a cytologist will interpret the thyroid biopsy results as. The first category is where there was not enough cells or tissue cells in the sample, and so that can often be non-diagnostic and often may need to be repeated. And otherwise, there's 2, 3, 4, 5, and 6, and there's really a range of the risk of cancer in those. So 2 is benign, and the risk of cancer is almost negligible, and 6 is a Bethesda category 6 nodule is almost definitely a thyroid cancer. And in between, the risk of malignancy can range from 5 to 90%. And so it can vary a great deal.
And I know you've done a fair amount of work with trying to characterize that in-between category, which I think is very helpful, especially for older patients who may be on anticoagulation due to atrial fibrillation or some other health issue. They may not be good candidates for general anesthesia, and thyroid surgery is still done under general anesthesia. And the same for maybe younger patients who don't want to lose their thyroid. Maybe you could comment a little bit about the tests that are available in 2017 to kind of characterize that in-between risk category.
Yeah, so for thyroid nodules where the cytology is what we call indeterminate, so it's atypical or a follicular neoplasm, also referred to as Bethesda 3 or 4 lesions, the risk of cancer can range from 5 to 30%, and that depends a little bit at the institution where the pathologist is working. There are several other studies now that are commercially available that can look at microRNA or mutations within the cells to determine if it's more or less likely to be a malignancy. And for certain patients, that can help guide the treatment. But that's a discussion that should be had between the patient and their healthcare providers.
So if my close friend on Cape Cod has a biopsy and it's benign, then she probably doesn't need anything else done.
With a 1.6 centimeter thyroid nodule that is not causing her any problems, sure, she probably would just need continued observation of the thyroid nodule.
Suppose it comes back papillary thyroid cancer, and for sake of argument, we'll say she's 55 years old.
So that's a little controversial. So for papillary thyroid cancer, which is the most common form of thyroid cancer and for whom the majority of patients are going to have an excellent prognosis, the options are at 1.6 centimeters would be probably not observation alone, which we sometimes recommend for patients with thyroid cancers under 1 centimeter. Sure. But at 1.6 centimeters, she could either have a thyroid lobectomy, where just that 1/2 of the thyroid is taken out, or a total thyroidectomy, where the entire thyroid gland is removed. And that would depend, as you mentioned, on a patient's age, on the characteristics of the thyroid nodule, and if there are risk factors in the patient's history. So a history of thyroid cancer in the family, or a personal history of radiation, sure, to the head or neck area.
And why not just take out the entire thyroid? Why would we leave half of the thyroid behind in a patient like this?
So there are a few reasons. One is, again, because the thyroid cancer has an excellent prognosis. The thought is that taking out the whole thyroid may not affect a patient's long-term survival. So the consequences of taking out the whole thyroid, the patient has to make a decision based on their own preferences. The consequences are being dependent on thyroid hormone replacement, and that's a daily medication they would have to take for the rest of their lives.
To replace what the thyroid makes?
Correct.
We take levothyroxine. Some people referred to it in the past as Synthroid, but now we use pretty much the product name of levothyroxine.
Correct.
Routinely.
And then there's also the risks of surgery. So while the risks of surgery are small in thyroid surgery, there are real quality of life issues that can be associated with an injury to the recurrent laryngeal nerve, which can affect the quality of someone's speaking voice, sure, and or having a low calcium because of any damage to the parathyroid glands.
Yeah. So for the sake of argument, suppose it comes back papillary thyroid cancer, we decide to take out the whole thyroid, and her question is, well, gee whiz, Doug, I have a few friends who needed to go on thyroid hormone either because they had thyroid surgery or their thyroid just stopped making thyroid hormone, which is relatively common, and they seem to gain weight. And I'm sure you've heard that probably every week. Is that fact or fallacy that if your whole thyroid is removed and you take thyroid replacement hormone, simple pill once a day, that you may gain weight?
It may be a little bit of both. I think thyroid hormone is, for the majority of patients, relatively simple to replace and will mimic their own body's natural production when they had their thyroid identically. There is a very small percentage of patients for whom taking thyroid hormone, which is synthetic, is difficult to manage, and that's where endocrinologists play a big role. So there's probably a small percentage of patients for whom taking thyroid hormone is going to be difficult, and that's another thing to consider when we have that discussion about half versus whole, you're taking out your whole thyroid.
Yeah. Great. Well, this has been wonderful, Tracy. Thanks,
you. Doug.
Thank you so very much. And I'd encourage all of you who would like to learn more about thyroid cancer, visit Dr. Wang's endocrine surgery website in the Department of Surgery. And there'll also be additional information that follows at the end of this video. Thanks again, Tracy.
Thanks.